Good morning and welcome to today's topic. Today we are going to discuss acute kidney injury or AKI. It is quite common condition and many times it could be result of most of the time it is result of many different factors like pre-renal, renal or post-renal. Like renal can also be called as intrinsic. So formerly it was called as acute renal failure and uh, many of the times it happens in the patients who are hospitalized. So now, what we will discuss in this one is we will start with the definition. So, how we define this thing, or AKI, how we define AKI, acute kidney injury, is like abrupt decline in renal function, leading to increased nitrogenous waste products. So, of course, like all the nitrogenous waste products which are excreted by the kidneys uh, when they are raised, of course, we call it as acute kidney injury. And before it was called as acute renal failure. So, like it's a syndrome, you can say, when the renal functions are decreased. And as you know, how we measure the renal functions, we measure the renal functions by measuring what serum creatinine, right? So, or you can say one of the thing we can check is urinary output. Okay, so what happens like there is decreased renal function which we measure by serum creatinine or by measuring urinary output. So they are decreased, and when and of course like this one here you are using the word abrupt, but it should be within hours to days. Okay, of course, like it is an acute condition, so hour to days. If it is happening in weeks to months, so it is chronic. But when it is occurring in hours to days, it is acute kidney injury. So different definitions of acute kidney injury exist, by the way, but there are different guidelines. One of the guidelines is called as KDIGO, KDIGO, the Kidney Disease Improving Global Outcomes Guidelines. So what they define kidney disease global, improving global output uh, guidelines. Define AKI as rise in creatinine to greater than 26 micromole per liter within 48 hours. Okay, or they say like either the rise in creatinine is greater than 1.5 uh, times the baseline. Okay, within 7 days. So like these are their guidelines. Like if you, or they say like if the urine output is less than zero point 0.5 milliliter per kilogram per hour. Okay, for more than 6 hours. Okay, so like these are the different types of, you can say, guidelines which is given by uh, kidney disease improving global outcomes, right? So this thing. they name it like this one. Again, like the same guidelines, they also give the staging. They say if the creatinine is more than 26.5, it is stage 1. Okay. In this one, like the urine output is less than zero point 0.5 for 6 to 12 hours. The stage 2 is when the creatinine is 2.0 to 2.9 times the baseline. And stage 3 is when the creatinine level is more than 3 times the baseline. So uh, stage 1 is when creatinine level is 1.5 to 1.9 times the baseline, and stage 2 is when the creatinine level is 2 to 2.9 times the baseline, and stage 3 is when the creatinine level is greater than 3 times increase in, like to the baseline. So these are all the, you can say, guidelines, but of course uh, okay, now this is a common condition. As I told you, AKI is a common condition. Okay, and how common? It is so common that 18% 18% of hospitalized, okay, as well as 50% of uh, ICU patients, they get AKI. So it is like so common. Of course, like people who have pre-existing kidney disease, increasing age, males, any comorbidities like diabetes, cardiovascular diseases, malignancies, they are at more risk of getting AKI. And the most common causes of AKI is sepsis, major surgery, cardiogenic shock. Okay, so so actually we classify the AKI under some other headings. Okay, you can say the most common causes of AKI. They are many, like sepsis can be cause AKI, major surgery can cause AKI, cardiogenic shock can cause AKI. So see, like all in these two, there will be decreased renal perfusion. Hypovolemia can cause AKI. Drugs can cause AKI. Hepatorenal syndrome can cause AKI, as well as obstruction can cause AKI. So, like these are the major causes or common causes of AKI. But when we divide it, like we do this thing under this thing. Like, what are the causes of AKI? If you can see over here, um, AKI can simply be classified or on these things like pre-renal. So what happens in pre-renal? If anything is leading to decreased renal flow to the kidneys, and then there is renal, which is also called as intrinsic, means like some intrinsic renal diseases are there, and post-renal are mostly obstructions. Okay, so when there is obstruction to the renal blood flow, or sorry, urine flow. So pre-renal, of course, when there is less uh, blood supply to the kidney, could be due to hypovolemia, could be due to disordered autoregulation. Okay, like hypovolemia causes are very, very, very easy. See, it could be decreased vascular volume, like hemorrhage, GI losses, skin losses, and renal losses. It could be due to decreased output or cardiac output, like low cardiac output. Okay, shock, myocardial infarction, though it is not written here, of course, that is also the cause. It could be due to systemic vasodilatation, like sepsis. sepsis causes systemic vasodilatation, and it could be due to renal vasoconstriction, like hepatorenal syndrome. Okay, hepatorenal syndrome, or like that will occur in cirrhosis, of course, right? So, see, few of the causes are not written here, but you can include them. And uh, this thing we have already discussed, right? What is disordered autoregulation? You know what is ACE inhibitors and what is their action? I talked about in the previous lecture. NSAIDs, calcineurin inhibitors, and hypercalcemia. All this thing can lead to renal failure. When it comes to the renal causes, again the same thing. It could be glomerular diseases like glomerulonephritis. It could be interstitial disease like acute interstitial nephritis. It could be tubular disease like acute tubular necrosis, right? And it could be vascular problems like vasculitis, malignant hypertension, thrombotic microangiopathy. We had discussed all these things. Cholesterol emboli or large vessel disease. Like in the previous lectures, we had discussed now all the things. So I think there is no need to explain them. Uh, okay, so now again, just interstitial diseases could be due to drugs, could be due to infections. Okay, and this vascular diseases can be due to HUS or TTP or DIC. We had discussed this thing, right? When it comes to the post renal causes, there could be a stone, a malignancy, a stricture, a clot, and that's why, whenever it is one kidney, then this is very common cause, right? Because two kidneys, if there is one kidney is block, of course, second kidney will keep on functioning. Or it could be extrinsic compression like pelvic malignancy, prostatic hypertrophy, all these things, of course, look, they can cause post-renal type of AKI. Okay, so very easy to remember. Like simply there could be pre-renal causes, there could be renal causes, and there could be post-renal causes. Okay, so now uh, whenever it is pre-renal etiology, uh, we can get some clinical clues to get an idea that either it's pre-renal, either it's prerenal, either it's post-renal. For example, in pre-renal etiology, if you will see, if you will remember, most of the causes are due to decreased blood flow to the kidneys. So clinically, you can get decreased blood pressure, increased heart rate, or orthostatic hypotension, okay, or orthostatic heart rate and BP changes. So of course, like all these things will point towards what? That the intravascular volume is low. Okay, so now when the intravascular volume is low, so of course there is decreased blood flow to the kidney, and when there's decreased blood flow to the kidney, so there will be less filtration fraction, less GFR. So the nitrogenous waste products will be excreted less from the body. So in the result, what will happen? That there will be increased urea as well as increased creatinine. But in this case, the urea level will be far more than the creatinine level, right? So this thing is important. Now, uh, see, in this condition, when the cause is pre-renal, basically the kidney functionality is normal. The only thing the kidney is having is less blood supply to the kidney, of course, which can lead to further kidney damage. But in the start, because the kidneys are getting less blood, okay, and that's why there is less GFR. So how the kidneys will respond? The kidneys will activate renin, angiotensin, and aldosterone system, and what they will do, they will start conserving the water as well as the sodium. So when we will check the urine sodium levels, okay, in these patients, what we will found that the urine sodium excretion will be decreased, like it will be less than 10 to 20 millimole per liter. Why? Because the kidneys are conserving more and more sodium as well as water. And because there is less intravascular volume, and the kidneys will try to retain more and more water, so the urine which will be formed will be concentrated, and when you will check the urine osmolality, it will be way higher than the blood. Simply, like the blood osmolality is around 290 to 300 milliosmol, but see in this one the urine osmolality is way higher because the kidneys are producing uh, a way concentrated urine. Okay, and the fractional excretion of sodium will be less than 1%. Why? Because the kidneys are uh, conserving more and more sodium, and kidneys are conserving more and more water. So this is the clues to pre-renal etiology. When it comes to the renal etiology, um, the clues or the things which we can get now the thing is different. Of course, it depends on the clinical context by which what you can say the thing is happening. So when we do the urine analysis in these patients, we can get pigmented granules in the case of acute tubular necrosis. We can get WBCs in case of acute interstitial nephritis. We can get RBCs, cast, broken RBCs in case of glomerular nephritis. And systemic features will be like of anemia, thrombocytopenia, hypertension, mild to moderate extracellular fluid volume overload. Like depends on what is the cause of the renal failure, right? And interestingly, when it is uh, post-renal type etiology, okay, so maybe you will found a known solitary kidney, like because I told you here that it is more common when the kidney is single, right? It will be a old age patient, or there will be could be some like recent retroperitoneal surgery. There will be anuria. There will be palpable bladder because that will be full. Of course, if the obstruction is after the bladder, and ultrasound will shows what hydronephrosis, like the kidneys will be full of water. So quite easy to remember, guys. The causes, the clues for prerenal, the clues for renal, and the clues for postrenal etiology. How we differentiate prerenal from acute tubular necrosis? Because the postrenal are mostly diagnosed clinically on examination. See, in pre-renal etiologies, when we do urine analysis, it will be normal. But in acute tubular necrosis, we can find pigmented granular cast or RBCs. When the condition is pre-renal, the kidneys are functioning well. Remember, in this one, the kidneys are not functioning well. In this one, the kidneys are functioning well. So whenever the etiology is pre-renal, the kidneys are functioning well. They are conserving more and more and more sodium. So the sodium excretion will be less than 20. But here, the kidneys are not functioning well. So they will lose more and more sodium because they cannot conserve them. The same thing we will see when we will see the ratio oil in the urine of the sodium over creatinine. Okay, it will be less than 20 because again the kidneys are conserving more and more sodium in this case. Okay, but throwing out more and more sodium in this one. Urine osmolality in this one will be higher than 500. Why? Because the kidneys are fine, they are trying to conserve more and more water, but here it will be less than 350. And again, the fractional excretion of sodium will be less than 1% in pre-renal and more than 1% in renal. Okay, so if you have done this thing, now we are going to discuss some more what you can say details of how to treat or how to manage the patients of prerenal AKI. Okay, whenever there is AKI, what we can do, right? So of course, like we will do investigations, we will do treatment, okay, we will do management. So uh, in this one, the most important thing is uh, how to manage or the clinical approach to AKI. Clinical approach to AKI. Okay. Uh, What investigations we will do, by the way? Like we can do, like, if you remember from this one, of course we can do a lot of investigations, right? You can do a CBC, okay? You can do electrolytes again for this thing, and many of these things, right? You can do creatinine for kidney, urea to differentiate between pre-renal or renal, right? You can do electrolytes. You can do urine analysis, check for albumin, check for hemoglobin, check for WBCs, check for specific gravity, check for culture and sensitivity, check for microscopy, check for cast, check for crystals. If there is any post-renal cause, you can of course pass a catheter and take the sample. Uh, One of the way to uh, what you can say rule out most of the pre-renal causes, sorry, because in this one the there is hypovolemia, is something called as fluid channel challenge test. Like what we do, we give a bolus of fluid, okay, and see if the kidney started working again or not. So this thing, you can do ultrasonography for all these things. Of course, ultrasonography will tell you if there is any hydronephrosis, any renal obstruction. You can do renal biopsy to check for all these things. Okay, so a lot of investigations are done, can be done. But like how we will discuss is like how we are going to manage or uh, treat this one, right? So first of all, uh, like whenever anyone comes with acute kidney injury, we check the condition of the patient. For example, if the patient is coming with uh, life uh, threatening uh, complications, okay, so of course like it is an emergency, right? What are the life threatening complications? Like hyperkalemia. Okay, now what is hyperkalemia? Of course, like whenever the kidneys are not functioning well, uh, the potassium levels will be raised, and once it will be raised, it can lead to cardiac arrhythmias. Or for example, if the patient have pulmonary uh, edema, right? Of course. Okay, any patient who's coming with this life-threatening complications, what should be the action? Straight to dialysis, right? Because of course, like if you will not do dialysis, the patients are going to die. Okay, so uh, for example, if there is no, what you can say, no life threatening complications, then we can go on to other side of management, like what what are the different steps as to examine the patient, okay, and what to examine. uh, examine examine heart rate, examine blood pressure, examine JVP, examine capillary refilling time, examine uh, palpate the bladder. Okay, now why this thing is important, see guys, because when you are going to all the do these things, you would understand either there is a pre-renal cause or post-renal cause. Like if the heart rate is more, BP is less, okay, CRT is reduced, and palpate the bladder, if it is full, it could be post-renal problem, right? So this is going to give you a lot of information, right? Either the patient have pre-renal or post-renal cause. So a very, very, very important point. So if you found any of the pre-renal cause, what we can do? We can treat uh, hypovolemia. Okay, hypovolemia should be treated. Now, you can say it could be a treatment of hypovolemia, or it could be a investigation, which I was talking about, that is called as the fluid challenge test. So what we can do, we can do a uh, bolus of IV fluid. Okay, so what we gave is like 250 to 300 ml of anything, okay, uh, any fluid. Of course, normal saline can be given or anything can be given. So, and we see the response, like either the kidney started functioning or not, okay. So we can give like around 2 liters of the fluid, but if there is no response after giving 2 liter of fluids, then of course stop and get some specialist help, okay. Then we monitor the patient, okay, monitor the patient for different things like uh, fluid balance, okay. So how we can do fluid balance monitoring by passing a Foley's catheter, okay, and of course, like after passing the Foley's catheter, uh, do what you can say hourly urine output monitoring, right? Should be done, okay. Keep on checking the potassium, very 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 important. Okay, potassium, because they can cause what you can say arrhythmias, right? So hyperkalemia can lead to arrhythmias. And vitals every hourly, or depending on the patient, every 4 hourly can be fine as well. Keep on checking the lactate levels for sepsis, or lactate levels, or you can say other signs of sepsis, right? Signs of sepsis. So of course, like they can lead to, and we will keep on doing daily creatinine. Why? Because the creatinine will tell us like how the kidneys are functioning. So daily creatinine should be done until they are decreasing. Okay. Then of course, like we can do it like less often. Okay. So uh, the level of creatinine, by the way, they lag around 24 hours behind the clinical response. Okay. So if the creatinine are becoming coming back fine, so it means like the kidneys are functioning well, right? And then of course, like you go for all the investigations, if whatever, like to search the causes, okay. And like the same thing which I was talking about before, like all the investigations which we can do in this one, which could be again urine examinations, which could be ultrasonographies, okay, which could be LFTs to check for hepatorenal syndrome, which could be to check the platelets, okay, to check for TTP or HUS. Uh, you can do what you can say check for auto antibodies, okay, to think about all the conditions or rheumatological conditions which can cause renal failure, okay. So all these things should be checked, of course, in these patients. And of course, there is a lot of other investigations which we can do, as I told you already, and not just these. Is like CBC should be done, okay, as well as electrolytes can be done, or creatinine levels, of course, that they are very important. We are doing it daily, by the way. Blood urea nitrogen, of course, okay, as well as urine dipstick can be done, and microscopy, of course, of the urine, and culture of the urine to rule out other things. Urine routine examination, by the way, they give you about caste and all these things, okay. So this thing is important. And of course, like if there is needed, if you think like it's needed, so biopsy can be done. Of course, it will tell you a lot of what you can say the condition, what the kidneys are going down, okay. So now one of the thing is, for example, if it is pre-renal cause, so of course we know that uh, we have to correct the volume status and the thing will become fine. For example, you can give blood, you can give normal saline, you can uh, hold down ACE inhibitors or ARBs, okay, because simply they are the one which is what you can say stopping the conservation of sodium in water, and also stop any renal, any nephrotoxic drugs like NSAIDs. Okay, so and one of the thing, we don't prefer to give NSAIDs, especially to the patient when they have diarrhea, when they have heart failure, when they have renal failure, because NSAIDs are nephrotoxic anyways. Okay, so um, wherever it is renal causes, of course, again, discontinue any nephrotoxic drugs, treat any infections, okay, and provide supportive cares, immunosuppressive cares if it is some rheumatological conditions, okay, or corticosteroids can be given as well. Remember that renal transplant is not the treatment of acute kidney injury, because many times, it revives back the people, the kidneys, like the kidney shutdown basically come back to normal, especially when the patient is young and there is no comorbidities or multi-organ failures. So whenever it is post-renal causes, of course, like depending, like if it's a stone, treat that. If it's obstruction, remove that. Most of the time, a Foley's catheter is passed in the hospitals, or suprapubic catheterization can be done. Sometimes, rarely, nephrostomy can be done, or stenting can be done. Okay, so like these of the type of things are done. But and if there is any indication for dialysis, go for that, of course. Like dialysis will, of course, uh, help the patient in these cases. Okay, so treat sepsis, of course. Now depending on the reports, by the way, see, depending on these reports, whatever we are getting, of course, we are going to act accordingly. Like treat sepsis if you found that patient have sepsis, so treat that. Stop the drugs, or stop the nephrotoxic drugs. In the hospital setting, guys, two, what you can say, important drugs which you have to remember. By the way, there are many, or you can say three drugs, if I will tell you, which we will stop. One is NSAIDs, we will stop for sure. Second thing is uh, ACE inhibitors and ARBs, which we must stop, okay, for sure. And the third thing is aminoglycosides, okay, like gentamicin, omecacin, amikacin. They should be stopped as well. Uh, so, uh, if the patient is taking any drugs, so adjust their dosages, okay, because remember, uh, medication dosages. Why? Because most of the drugs, they are excreted from the kidneys. So uh, whenever there is renal failure, chronic or acute, we must adjust the dosage of the drugs to make it in according to the GFR, and this thing is very important. So adjust the medication the patient is taking according to the renal failure dosages, right? And provide nutritional support, avoid any radiological procedures, especially in which contrasts are used. So like this is very important. So of course, this thing is like this is how we clinically approach the patients, and we treat the patients, and we keep on looking at the response. If the patient is developing any uh, indications for dialysis, of course, we send the patient for dialysis, okay. Like hyperkalemia is the indication for dialysis, acidosis, fluid overload, uh, uh, pericarditis, okay. All these things are the indication for dialysis. So like if there is an indication for dialysis, of course we send the patient for dialysis, okay. And then we put the patient on dialysis. So like this is how we do that. And rest, like if you know how to manage the pre-renal as well as the post-renal, okay. Now in renal, by the way, we cannot do some intervention, rather we have to just decrease the damage to the kidney. So what we do, like we stop the nephrotoxic medications or treat any infections which they have. Okay, so uh, like that's it. Like this is all about acute kidney injury, right? And yes, like I always like this is one of my favorite questions, not mine, but like many people they really like this thing, uh, or you can say it's a homework for you guys. Uh, look, take a look at. Uh, you can say write down ECG or read about ECG changes in hyperkalemia. Okay, and one thing, uh, how we manage hyperkalemia is very, very, very important thing. Okay, and it is a question which will come again and again and again. Okay, so whenever there is hyperkalemia, okay, uh, especially when the potassium levels are more than 6.5 millimole per liter, or either on the labs or either you will see the changes on ECG and the potassium is that more than 6 millimole per liter, treat that. Okay, so when the potassium levels are what more than potassium levels are greater than 6.5 millimole per liter, right, or greater than 6 millimole per liter with ECG changes. Okay, you will see the ECG changes yourself. Okay, um, remember, treat that. Okay, this is very, very, very important. So how we treat, by the way, treatment is very easy. Like first of all, we give them 10 ml of 10% calcium chloride. Okay, now why we give this thing is basically hyperkalemia can lead to uh, cardiac arrhythmias, and basically uh, like this calcium which we give, like calcium chloride, or we can also give, by the way, calcium gluconate. Okay, or again, that is also easy to remember, like it is 30 ml of 10% calcium gluconate. Okay, so basically we give it like IV, like over 5 to 10 minutes. Why? Because this one is cardioprotective. Okay, and it will not change the potassium levels, but what it will do, it is going to go uh, and stabilize the cardiac membrane. Okay, or simply protect the heart from any arrhythmias. Okay, so that thing is important. Second thing is, like, again, we can give them intravenous insulin. Okay, but of course insulin can cause hypoglycemia, so what uh, we give insulin in glucose. Okay, so that the patient should not have hypoglycemia. So 10 units of insulin can be given in 25 gram of glucose, or uh, like there are different type of combinations in that. Okay, or 50 ml can be given, or 125 ml can be given of 20% glucose, like anything is there. So if you know, like, what is the function of insulin, by the way, uh, whenever we give insulin, what it does, basically it moves the what you can say, potassium from the extracellular fluid to intracellular fluid, or simply it stimulates the uptake of potassium inside the cell, right? So that's why, like, it lowered the serum potassium levels. Okay, around zero point 0.5 to 1 millimole per liter over half an hour to 1 hour. Okay, so that is very important. But remember, like, keep on looking the patient for hypoglycemia, because the patient can develop hypoglycemia. One more interesting thing, we can also give salbutamol. Now, salbutamol, what is that? It comes by Ventolin name, and we can give a nebulization. Like, if someone have asthma, they know what is salbutamol. Okay, so salbutamol is also causes the potassium shift intracellularly. Okay, but of course, like, high dosages are required. So simply we keep on giving them nebulization of salbutamol. But remember, like the side effect of giving this drug is what? Because it's a beta agonist, so it can cause tachycardia. Okay, so avoid in cardiac diseases because it can lead to arrhythmias. So very important thing. Now, definitive treatment to remove potassium, okay, is like we can also give some potassium uh, exchange resins, okay, but like they are slow working. But how like we can remove potassium from the body, or the definitive treatment uh, of removing potassium is how we can remove the potassium from the body, okay, is of course by renal replacement therapy. Is by renal replacement therapy. So what is renal replacement therapy? Of course, we can put the patient on dialysis, okay. With the patient, we can put the patient on dialysis, of course, like that is the hemodialysis or whatever, hemofiltration or peritoneal dialysis, whatever, okay. All these are renal replacement therapies. So we can like whenever we have to, if these things are not working, which we already talk about, so we send the patient to, or transfer the patient to the renal team or the nephrology team, of course, like they are the one which can give this renal replacement therapy, right? So thank you so much, guys, for listening, and our next lecture will be about chronic renal failure, and then but the last topic for nephrology, that is about UTIs, okay. Because the stones you will study in surgery. Okay, thank you so much.